So good afternoon and a very warm welcome to all of you who are joining us today for this peer-to-peer learning meeting of the GLC4HSR or the Global Learning Collaborative for Health Systems Resilience. I'm Stuti Shukla. I'm the communications manager here at Access Health International, and I work with a team that manages and oversees the overall communications, relations, and events here at the collaborative. I'd like to begin by giving a very quick snapshot of what the GLC4HSR is in the interest of those who are joining us for the first time today. The GLC4HSR is a multi-regional network of health systems experts, including policymakers, practitioners, researchers, amongst others, who come together with a vision to build resilient health systems. Since our official launch in March last year, we've seen a steady growth. We now have about 55 members and advisors across 15 countries. We have also begun work on initiating 4 other country chapters apart from India, and the speakers that will be following me will shed more light on that. Peer-to-peer learning meetings for us are an important channel facilitating the co-creation and exchange of knowledge that the GLC4HSR strives for. It is a platform that is designed to enable a free flow of information and reciprocal learning amongst peers. Today is the 4th such meeting in the series, and today we will focus on the need for innovative surveillance methods in the wake of health shocks. It's going to be a 90-minute session that we will begin with context settings, and we will then invite our eminent speakers of the day to take forward a panel discussion on the same. I now invite Dr. Krishna Reddy to set the context for the meeting. Dr. Reddy is a senior practicing cardiologist and the South Asia Regional Director of Access Health International, which is currently the Secretariat of the GLC4HSR. Dr. Reddy is also the president of In Order, the Health Systems Institute. Over the years, he has founded many enterprises and initiatives with a mission to evolve models of high quality and affordable and accessible healthcare. So without further delay, I hand it over to Dr. Reddy to please take this meeting forward. And once again, a very warm welcome to all of you.
Yeah, thanks, Stuti, and also warm welcome to all the participants for today's learning event. This is an important topic, one of the key themes that the GLC has taken up. So as a part of the thematic work around the surveillance, already the interested group has been working on extensive systematic literature review on the various frameworks that exist for surveillance. And also the lot of lessons that have been coming through the last 2 years during the COVID pandemic. Each one of us understand the criticality of the surveillance in terms of the rapid detection and alert systems to prevent pandemics and epidemics. So this becomes a central theme for building resilience health systems. Most of the health systems have been evolving along with technologies in terms of effectiveness of surveillance systems. Especially, there has been a lot of adoption of information technology systems to make it much more effective over the last few years. But what COVID has witnessed is a kind of a disruptive innovations in the application of the digital technologies and the molecular technologies, especially the genomic surveillance methods. There is a tremendous excitement about the potential of the new innovative technologies as a part of the surveillance. But at the same time, I think we have to be circumspect and a pause to take a much more comprehensive view whether these surveillance innovations can become the new normal along with the traditional surveillance systems. One of the concerns that exist with these surveillance systems is whether all countries have the capacity and the capability to integrate some of these innovations, or is there a need for a global health policy to enable these global public goods in terms of the digital public goods as well as the molecular public goods made available to countries which cannot afford or do not have the capacities for these? The second concern, which always with new technologies, is their cost effectiveness, because one of the key attribute of a good surveillance system is their cost effectiveness. The third emerging concern around some of the digital technologies and surveillance systems is the great concerns around the individual privacy and the security. Because some of these surveillance systems, if they are carried forward into the normal times, whether there is a potential for misuse of some of these surveillance systems. So these are, I think, some of the concerns why there is a tremendous potential for these technologies to make surveillance much more effective, especially in the context of the globalization and the movement of people across the world. Millions of people moving across countries in a day. There is a need for rapid alert mechanisms and the rapid detection through use of advanced digital technologies and the genomic molecular technologies. This is the context, I think, for today's learning session with the two eminent speakers. Before that, I would like to introduce Dr. Mohammad Akhtar Hussain, who will be moderating this session. He is a fellow of public health medicine. He did his master's MD in community medicine from India, and then later did his PhD from University of Queensland. Over the last many years, he has an extensive experience in public health, including the infectious diseases, health systems research, and primary health care and other related areas. Currently working at Bowen Southwest Public Health Unit in the state of Victoria, Australia. He has published many articles in the peer-reviewed journals and scientific journals. Without much taking time, I would like to hand over the proceedings to Dr. Mohammad Akhtar. Over to you.
Thank you, Dr. Reddy. Thank you, Dr. Reddy. It's a great pleasure for me to moderate the session with this two eminent experts in this area of surveillance. I think Dr. Reddy set the scene quite well regarding the newer development that happened over the last 2 to 3 years in surveillance, and whether we take it or not, it has forced us to accept a lot of newer developmental technology in terms of surveillance, in terms of genetic surveillance, and many more, like sewage water, and how can you use those sewage water surveillance for detection of newer diseases or any other antimicrobial resistance and so on. So it's a great opportunity for me to moderate this session with Dr. Angela and Dr. Avinash. Not wasting a lot of time, I would like to introduce Dr. Angela Chaudhari, who is the health practice lead for Catalyst Group and CEO in waiting for Swasti. She has 21 years of experience in public health in India and internationally. She has the practice lead at Catalyst Group at the moment. What I said, her more recent work has involved leading the health response of COVID Action Collaboration, a people-centric multidisciplinary initiative that supports the most vulnerable and not just survive but thrive during the pandemic. She has co-designed health and well-being interventions at global scale and helped raise more than 1.3 billion US dollars for TB, HIV, and malaria for 12 countries. She continues to support government to improve their health outcome and strengthen their system through better human resource management, program design, and planning. I would leave the stage for Dr. Angela for the presentation. Yeah.
Thanks, Dr. Akhtar, and thank you, Access Health team and GLC4HSR for having me. Thank you, Dr. Akhtar, for the introduction. I'm very happy to be here, and And actually, Dr. Reddy, Dr. Uma, and I have discussed our work in surveillance. And I think it was last we met in Bali when you said you need to speak about the work that you're doing. So it makes me very happy to be here after a few months in this panel. Could we just go to the first slide? This is somewhere in between. So this session is really about local innovation. And I just want to say that surveillance systems can be as simple or as complicated as we can make it out to be. As we are getting on trying to find the first slide, thank you. I will just quickly say where we started off. So as you know, I help run Swasti. Swasti is a health catalyst that works for the most marginalized community, and central to everything is health equity. So you might be wondering, why is an organization like Swasti getting involved in something like surveillance when it is really the job of the governments to do that? So the context behind it and the history behind it is essentially that we were trying to solve for inequity in two ways. Inequity in information, because only government had information and it was sporadic and it depended on testing. And inequities in testing, because testing kits had run out and only the privileged people were able to get them. So we were trying to solve for those two inequities. And what is one way, one of the ways that we solve for that is an idea that we got from, sorry, I think there's someone else speaking as well, was an idea from a paper that we read written by KW Water Research Institute in the Netherlands, where they had found COVID strains in wastewater, and we said, this sounds like polio. Is this something that might solve for the inequity of both information and diagnostic tests? Because people need to know how much of risk they have besides the numbers we got from hospitalizations. So we set out to solve for wastewater surveillance, and we wanted to look at if this was even possible in lower middle income setting. Therefore, we didn't even go to the sewers. We went to the open drains because we wanted to really hit out and target communities that have no information to see, which are typically not in sewer connections, to see whether we were able to do a risk profiling, towards COVID at that time. So we set out to, could you go to the next slide, please? So what we set out to do, yes, is our dream is that India actually recognizes and utilizes environmental surveillance, particularly with wastewater, as a critical public health tool. We have many critical public health tools. We use NFHS, we use DHS, we use some amount of clinical data to do planning. But actually, wastewater is liquid gold. It holds a lot of information. And if we analyze and tested it, we would be able to plan for the future. So this is the vision that we're going with. Next, please. Thank you. And as I said, that during COVID, there was a lot of interest around wastewater surveillance. India uses this for polio, but we do pretty much not do a lot of it. Around the world, there's been an interest in environmental surveillance for COVID, but most of the wastewater surveillance now, as I understand, because my team is tapped into the global climate in this area, they've actually been closed down, and some of them slowly started up again during right now because of the waves happening in COVID, in China, Japan, Brazil, etc. But most of the wastewater surveillance fairly active in 2021 and active in 2022 have pretty much died down. Indian government started showing quite some interest. There was a limited tender that was released by the Department of Science and Technology. So the innovation piece of it is still alive, but mainstreaming it into, say, Ministry of Housing and Urban Development and NIUA has been suboptimal, I would say. But as you know, I mean, I think I'm not going to preach to the choir and say, what does environmental surveillance do for you? So I'm going to skip to the next slide. This is what, because we were talking about local innovation, I would be remiss if I just sort of, skip past the process that is used essentially. And this is a very simple collecting. I have a video for you at the end that will showcase the local innovation. Is not sophisticated as some of the wastewater surveillance that is happening in the US, where people pick it up using automated samplers and then they transport it into refrigeration boxes through UPS packers and sends it to the labs. It's very simple process that we use here in our country. Please move to the next slide. And I don't know what happened to this slide, but this is a snap of our dashboard that basically shows if the infections are going up, if they've stalled, or they are going down. And you will see, green arrows going down is an antithesis of all arrows and signs that you have seen earlier. But in this case, this is COVID, and therefore green signs going down is a good sign. Move on, please. This will not be possible to go to scale if there was not a strong digitization of the initiative. So I want you to imagine that when the sewage collectors go out, they have clean, there's a shop where they have clean bottles, and they're loading their ice boxes because the wastewater has to be maintained at a temperature. They actually have stickers with QR codes that locates the sample. Those QR codes are mapped to the GPS of the sites that they are sampling. It is mapped to the wastewater collector. The time of the visit is mapped as well because there's a strong digital backbone. It then goes, this sample is then mapped to the sample that is collected by the lab and processed. And then once it is processed, it then goes for RT-PCR. And if it is eligible for genome testing, it goes to a different lab because all of these things are happening with different partners here. But every single sample can be mapped from the beginning, from the drain all the way to the dashboard. And this therefore helps the central team to see, to check for quality assurance. And sometimes we have to do repeat samples if that's invalidated. Please move on. Yeah, so I want to say this, there's a difference between studies and surveillance. A lot of people are in India and in the region actually do environmental studies. Studies meaning you collect the sample, you study for whatever it is, and then you publish a report. But a surveillance means the information is out there and it's happening through time, consistently, and across a place at scale. And what is important for the surveillance, and what was our learning through that, is you're not only just solving for the science, but you're also solving for the communication. So it took us quite some time. We spent maybe the same amount of effort we did in cracking the science behind it itself, maybe even more, to understand what kind of dashboard can lay people understand. We're not here to prove that we are expert scientists that know certain things about COVID, but we're here to actually translate and make information asymmetry go away. So we work with politicians and administrators at the municipal corporation to say, how does this dashboard look to you? What are you interpreting out of it? How does this graph look to you? Is this something that would, is this a way that we would depict that? In fact, one of our first reports we shared with the government, they said, are you crazy? I'm going to lose my job, is what the municipal commissioner said, because of certain colors and fonts that we used in our report. So we had to work together to understand what is feasible, what is palatable, and yet provide the absolute true essence of the data. So that was a huge learning for us in terms of surveillance. And most important, keeping the online dashboard public and open and at real time. So we have the online dashboard. We use Twitter as our public facing dissemination. We also use LinkedIn, but we know LinkedIn has a specific group. The Twitter handle itself was retweeted and used by the municipal COVID-19 update and continues to be done so. So the government is owning it in its own way and disseminating it among the public. And most importantly is the sense making. This is only one of the tools of many other pieces of information that the government has. We don't have, for example, any idea about hospitalizations. We are not getting a sense of, what's happening in the airports. There's testing happening in the airports and some of the genotyping. So, and we have to also separate the noise from the signal. There's a lot of noise that comes in this data, but what is a real information and what is the noise is something that we need to separate the wheat from the chaff. And so that is why we have there's a WhatsApp group, and there was a shared Google Studio database and regular meetings, group-wide meeting with the government that help us make sense of what we were seeing. Move on, please. Yeah, and this is the dashboard of the sequences. Next slide, please. So the government wanted to, we wanted to celebrate 1 year, and this is just a picture of the Bangalore Municipal Commissioner, supporting the launch of the playbook and thanking the partnership consortium of maybe more than over 12 entities in terms of supporting them. There was asks on dengue, AMR, etc., so on and so forth, to also be layered on COVID-19. Please move on. And that's essentially how environmental surveillance can be used. Now, it's still under innovation, and it's still not mainstream. So there's a lot of work yet to be done. At the moment, Precision Health Platform is in 5 cities. The slides that I showed you is on Bangalore because we finished a good 1.5 years over there. We are in Lucknow, Trichy, Chennai, and Jodhpur. And we'll start seeing the data coming in fairly soon. But then these are the reasons where we can be using the environmental surveillance in the environment, in the community, human and animal tests. Pharmaceutical companies can also use, the global guidance, technical partners like WHO, etc., can use this information to push certain policy, use them as policy levers. And there is a space for many stakeholders. It's not only for labs, it's not only for the government, it's not only for the Ministry of Health. Actually, there are many other government agencies that need to be brought in to environmental surveillance to actually move surveillance into actionable insights and action on the ground. At the end of the day, this is not meant just for research, but it is meant for public health actions moving forward and improving the research allocative capacities of the municipal government. Next slide, please. Thank you. So just wanted to share, because this is possible, it was an upstream struggle, but really there's a recognition at city levels, and not just in Bangalore, but it's part of the technical advisory committee discussions on what's coming out in terms of COVID. In fact, this year we've had COVID, H1N1, as well as monkeypox. We dropped H1N1 because of the season, and monkeypox, after we found negativity for a good 3 months, we dropped that as well. So the way we've kept it is fairly agile. We're keeping COVID on for as long as it's important, but anything that's emerging infection, we quickly derive a protocol and add on to it, as long as there's interest with the government. And then when that interest wanes, we just drop it, because that's the nature of surveillance at the moment, and it's being run independently by us with the kind support of donors. But essentially, it should be that we work to improve the public health capacities of the local government officials. So we've been able to test and create new pathogens and new SOPs that can be used by even the simplest labs. We've simplified all the standard operating procedures to something that anybody can do and support the government. Sense making is something that we've protocolized, productized, and we keep reiterating. So the government also has these spaces like the technical advisory platform and other spaces that they have created to work with civil society and other technical partners to make sense of the data. Several national conversations had been ignited, and many of you are part of those national conversations as well. And we have developed new partnerships in new cities that are interested in something like this to get started on it. As you will see, Karnataka or Bangalore is sometimes one of the first movers in masking and bumping up vaccinations. Currently, their only source of information is the wastewater surveillance. And so this is my invitation to all of you here, that if you're able to support environmental surveillance in your cities and location, ultimately that's something that's going to help you with emerging infections, because patient diagnostic tests take a long time and take a lot of money. This is quite cost efficient. It's about, I would say, less than $100,000 for 18 months of continuous surveillance supporting the government. And so therefore, particularly for tier 2 cities that have less money allocated to public health surveillance, this is indeed an efficient method to conduct environmental surveillance. Next slide, please. So these are the things when we are starting off surveillance was the key consideration. When you're setting up surveillance, today it's COVID, tomorrow it's something else, God forbid. but how quickly can you get the test results out? How reliable? These are the questions that they'll keep asking you, so you have to be ready for it. How reliable is wastewater testing given temperature fluctuation, rainfall, and flow? What thresholds of your information should trigger policy action? And what agencies, institutions, and funding must come together to deploy surveillance in a sustainable way? Next, please. And the gaps and opportunities, I'm coming to the end, and then you can hear me that I'm speeding up on the presentation. That currently environmental surveillance is still limited to COVID and polio, but we don't know, polio information is not open to the cities, and that's why I've said it's opaque, but there's already complacencies regarding COVID, and it's losing its flavor. But environmental surveillance as a public health tool itself is very important and can be extended to many pathogens of pandemic potential. This platforms for sense making and advice is largely under leveraged. We spend a lot of time in government permissions, but it's actually the government who should be leading on something like this. And therefore, what is the role of public health professionals in that space? What is comprehensive holistic environmental surveillance look like? And how can we use the traction that has been gained from the COVID response? Thank you. I think I might come to the end and ending with the video. Can you switch to the next slide, please? Yeah, I'm not sure if the file has been loaded, but there's a playbook here that simplifies the surveillance itself. And I just leave you here with a visual of how we've run the surveillance system. Thank you.
This is the environmental surveillance for COVID-19 playbook, a step-by-step guide to conduct citywide wastewater surveillance for COVID-19. This playbook is to help organizations set up and implement the wastewater surveillance system for COVID-19 virus detection in partnership with local government and other partners. It structures how early warning systems of sewage surveillance can be set up in locations that have sewer connections, open surface and underground drains, and centralized sewage systems. The playbook outlines the detailed steps required to initiate and conduct wastewater surveillance in any given city, and is based on the critical learnings on environment surveillance surfacing from the Precision Health Program. The Precision Health Program that completed 1 year on the 27th of May 2022 responded to the need of the hour, where Bruhat Bengaluru Mahanagarapalikhe took Precision Health to scale across all 198 wards in the city, making it the first citywide environmental surveillance initiative for COVID-19 in South Asia. The playbook articulates and addresses this problem statement, or in the word of Clays, the plot, and breaks down the how and why for each step. It traces the 4 P's: plot, purpose, people, and places, and spans 3 acts: planning, implementation, and evaluation, to share ground learnings, experiences, and takeaways. The 3 acts and 4 scenes of the environmental surveillance for COVID-19 playbook are: Act 1, Scene 1, planning; Act 2, Scene 2, setup; Act 2, implementation; Act 3, evaluation. The section on stage direction covers the media policy, introduces the Precision Health dashboard, and shares limitations and challenges. The pull-out pages are the standard operating procedures that cover sample collection and lab processes. The annex provides a range of tools and modes that cover checklists, forms, using tech, and training documents. We hope that this playbook informs and inspires other cities to take up environmental surveillance.
Thank you. Over to you, Dr. Akhtar.
Thank you, Dr. Angela. That was a really wonderful presentation and giving us an insight about what's happening in terms of wastewater surveillance in Bangalore and in other places as well. I think we can keep the questions for the end, and we can have the question answer session once we finish Dr. Avinash's presentation as well. Yeah, is Dr. Avinash there?
Hello, Dr. Akhtar. Yeah, I'm in.
Hi, Dr. Avinash.
Hello.
Yeah, it's me. Yeah, it gives me great pleasure to welcome Dr. Avinash. He is a medical graduate with a public health post-graduation from London School of Hygiene and Tropical Medicine, and has more than 15 years of experience in health program planning and implementation at various levels, in starting from district till the national level as well. He has delivered a lot of program and led diverse projects in multiple areas, including multiple infectious diseases, surveillance, immunization, maternal, newborn child health, and many more. He has worked with renowned international organizations as well, like WHO and UNOPS, UNDP, IPA Global, and led a lot of different public health surveillance projects. Currently, I think he's working with the Japaigo and based in the state of Madhya Pradesh, and leading the public health surveillance project there. Under his leadership, Japaigo was honored by the Department of Health and Family Welfare, Madhya Pradesh, for strengthening public health surveillance at state level event in August 2022. I welcome Dr. Avinash, and over to you, Dr. Avinash.
Thank you very much, Dr. Akhtar, for the warm welcome. And I'd like to thank GLC, Access Health International, and all the partners for giving me this opportunity to present our innovative surveillance models. To introduce myself, I'm working as team lead surveillance in MPs since 2021. And I've been looking after infectious disease surveillance program strengthening through USAID supported NISTA project. And to talk a bit more about my organization, the Japaigo is an affiliate of prestigious Johns Hopkins University, and we work in diverse areas, including maternal health, family planning, reproductive health, strengthening health and wellness center, surveillance, gestational diabetes, etc. And we have been in India since more than a decade. And we are happy that we could contribute a little to strengthening health programs in India. To talk about more about surveillance. Surveillance has existed forever, but it gained its momentum and pace when COVID struck. An IDSP program, infectious disease surveillance program, was launched in 2004, but it gained its importance and pace after COVID struck. And earlier it was a paper-based reporting mechanism in which the data used to come from the field and facility level once a week as paper-based reporting through SP and L forms. S is meant for syndromic case reporting, which is done by ANMs. P is presumptive case reporting, which is done by the medical officers posted at PHCs, CHCs, district hospitals, and above. And L form is lab confirmed, which is reported by lab technicians and pathologists. So SPL was reported once a week in paper-based format, but as need for surveillance arose, IDSP transformed into digital mode, and integrated health information platform was introduced in April 21. And we were fortunate to be able to roll out it in 8 states, including MP, Maharashtra, and 6 northeastern states. So what we have done in IHIP, I would like to browse through the slides. Yeah. So I've talked about innovative surveillance models. So as I've already briefed you that we are supporting IDSP surveillance in 8 states. So since I'm based out of MP, so let me start with what we have done in MP to strengthen surveillance mechanisms. And next, please. So we have been supported by USAID, and we have been involved in IDSP through 3 domains. One is technical assistance, second is demonstration model, and third is innovations. In technical assistance, we are strengthening implementation of IHIP, which is a digital platform to capture information of SPLN forms. S form is syndromic, which is in IHIP is filled by ANMs using the mobile application, and they report the various syndromes including fever, cough, rashes, diarrhea, dysentery, animal bites, etc. And the information gets loaded into IHIP portal, and it can be visualized at all levels, district, state, and national level. So in strengthening of IHIP, several mechanisms were adopted. First was generating awareness on IHIP and building capacities of reporting units, as well as mapping of various reporting units into this portal. So we had mapped SPLN form reporting units, and in MP there are more than 11,600 S form reporting units, which are currently mapped, around 1,800 P form reporting units, and more than 2,000 L form reporting units, which are currently mapped into IHIP. Then capacity building part was a very important thing, and we started with cascade model, and at the state level we retained more than 300 nodal officers, medical officers, representative from medical colleges, and they went on to further train, medical officers at various reporting units, field level staff, and currently more than close to 4,000 medical officers are have been trained. More than 1,800 lab technicians have been trained. More than 11,000 ANMs have been trained in IHIP, and CHOs, community health officers, who are posted at health and wellness centers, are also being trained on IHIP. Apart from strengthening capacities on reporting mechanism, it was also important to develop capacity on how to identify and manage successfully an outbreak. So we have planned outbreak, the development of LRPs on outbreak investigation, and we have successfully imparted trainings to state as well as district IDSP team on identification and management of infectious disease outbreaks. Third was the capacity to analyze all the information, all the data which is being fed into IHIP. So we conducted a need assessment of district and state IDSP team, including epidemiologists and data managers. So what we found that there exists a need to analyze data visualize data as well as interpret it logically, and utilize it for action planning of surveillance activities. So we developed a course, data analytics course, divided into two parts: foundation course and advanced course. Training of foundation course has been completed, and more than 100 personnel, including state and the district IDSP team, have been trained on basics of data analytics, and advanced analytics is in process, and we will be rolling it out by first week of February, most likely. Now, in strengthening of IHIP, there were several other mechanisms involved, including strengthening the review mechanism, strengthening monitoring and evaluation mechanisms. In review mechanisms at state level, weekly review meetings are being held in MP, in which the status of reporting outbreaks, mentoring visits, reviews being held at district level, all are being discussed, and action planning is being done to improve upon the gaps and challenges. At district level, it is being reviewed at CMHO level as well as the DM level in DHS meetings, monthly, quarterly, as it happens in districts. There is also reviews happening at division level under the leadership of Joint Director, who is posted at the division level. So these are some of the mechanisms we have adopted in strengthening IHIP. One of the major component which was strengthening the data component. So apart from training of data managers and epidemiologists, we have also devised a dashboard and ranking mechanism to highlight, in a more easy fashion, what are the trends in reporting, where are our NRUs lying, never reporting units lying, are there any facilities who are reporting but reporting nil? So to ensure quality of reporting, we have also tried to develop a feeling of competitiveness among districts, and we developed a district ranking mechanism on some parameters like SPL reporting, the number of cases being reported, if there are single logins, single login I meant is that various reporting units, since it was a priority of government, and it got included in the CM dashboard, Chief Minister dashboard. So it gained a lot of weightage in MP, and to remain in top 5 or top 10, district started to report centrally at district level of using IDs of facilities as well as from reporting units, and they started reporting at central level using their IDs. So what we started was we tracked the login IDs and device IDs and tracked that who all districts are reporting centrally to ensure quality of reporting and develop ownership at each level. So that was also included in the ranking mechanism, and negative markings were provided to all the districts where single logins were more. So it led to a decline of single logins, and currently none of the districts are reporting substantially, using this single device. So it leads to improvement of quality of reporting. However, there are still few reporting which are happening, from single devices, and we dig down deeper, and we saw there are, if the facility is vacant, or there are multiple facilities attached to a single lab technician, non-medical officer. So those sometimes single logins are also happening, but they are minimal. So these was a quality mechanism which we have incorporated to strengthen implementation of IHIP. Then second was strengthening whole genome sequencing. So whole genome sequencing is a very important initiative by Government of India, and we supported the state through development of and maturing the whole process of sample collection, transportation to concerned labs, recording, reporting, tracking the results, and then channelizing the focus activities to affected districts as well as areas. So it led to identification of core areas which are affected with Delta or Omicron strains, and it led to improvement in surveillance activities. Third one is we are supporting in establishment and operationalization of integrated public health labs. So integrated public health lab, I will talk about a bit later in my next slides. Data analytics, I've already spoken, and so I'll like to move to demonstration models in medical colleges. As I've already told, we have trained staff and representatives from the medical college, and it included professors from community medicine department, medicine, pediatrics, microbiology department, and we have also trained private medical colleges. However, the reporting is still at very basic stage, and only few cases are reported in P form due to high footfall, and state is yet to provide data entry operators, which has been repeatedly requested by a medical college. So we are working with state to work out a strong mechanism to address the challenges faced by a medical college, but they have started reporting, but still it needs to be strengthened a bit more. We are also working to integrate IHIP with health and wellness centers, and we have included IHIP in the induction course module for CHOs, community health officers, and new CHOs are regularly being inducted into IHIP, and old CHOs are being trained at the district and block level. Those CHOs are only being meant to supervise the entry of S form into IHIP mobile application. So in MP, we have stuck to that guidance by the Government of India. However, in other states, especially Manipur, we have trained all CHOs, and it is working on hybrid models. In some places CHOs are directly reporting into IHIP, and in some places ANMs are are reporting into SWC. So a mixed model exists in many states, but in MP we are trying to stick to reporting by ANMs. However, in few districts it is being done by CHOs also, where position of ANM is vacant. In urban surveillance, we have tried to identify challenges in reporting, because in large urban cities the clientele is mostly catered through private providers, and due to lack of any guidance or mandate by state for private service providers to report infectious diseases into IHIP, except some notifiable diseases. So we have tried to identify challenges, and we have enrolled a partner agency to conduct a quantitative and qualitative assessment of what are the challenges in urban cities, and we have done it in Indore, in MP, apart from seven other tier 1, tier 2, and tier 3 cities in other parts of the country, and its report is soon to be disseminated. So these were the demonstration models which we have supported. Under innovations, we have developed M-Screen application. So M-Screen application has been created during third wave of COVID to cater to the demand of tracking international passengers, which were mandated to be screened at entry point at various airports. So through M-Screen application, we have tracked more than 25,000 passengers, and it aimed to divulge the information from state level up till RRT team level on the passengers who have arrived and needs to be tracked, tested, and isolated as per Government of India guidelines. And what application did was ensuring the real-time capture of information of the passengers arriving, being tested, results being shared with them, they are being isolated at their home or institution level. So all these information was being captured through M-Screen application with the help of district as a district IDSP team and RRT teams based at field level. Another innovation was directed at improving community surveillance, where we found out that a big gap exists in timeliness of an individual to reach a facility as soon as a symptom arises. So what happens many times was that a person is suffering from fever, cough, and he used to wait for the symptom to get corrected automatically, or he used to visit some local provider, and many times the information was not being captured through our existing health mechanism at ANM or CHO level. So it was important to involve community directly to report their symptoms and develop a mechanisms to reach out to them at a very early level, so that we can identify timely an outbreak, and we will be able to manage it effectively. So a citizen-centric model named SHOCKS is under pilot stages in 2 districts, Guna and 2 blocks of Guna and slum areas of Bhopal. So these are the support which we are providing in the public health surveillance in MP, and I'd like to share some statistics on the overall progress what we have done. So I'd like to just request, please move to the next page. Yeah. So in the IHIP rollout, learning resource packages were developed, health workers were trained, sub-center village mappings to close to 55,000 villages have been mapped across 52 districts. Supportive supervision visits have been conducted. More than 300 visits have been conducted, and our checklist was being used by state and district level to develop a monitoring mechanism called strategic field monitoring system, which has been developed by state IDSP cell through support of Japaigo and Chai. So our checklist was framed as Kobo toolkit, and now state as well as district IDSP officials are conducting supportive supervision visits regularly, and more than 1,000 supportive supervision visits have been conducted by state and district IDSP team presently. We had also used telephonic surveillance as an effective tool to reach out to NRUs and poor reporting units. For outbreak management, over 100 infectious outbreaks were supported by the Japaigo team through physical presence or coordination, licensing, drafting reports, data analysis, etc. So it is a continuous process. Currently, last year, around 385 infectious disease outbreaks were reported, and which is a substantial rise from when there was paper-based reporting, and there was only few outbreaks which were reported, close to 20-25 outbreaks and annually, and which has grown substantially to more than 300 outbreaks. Next slide, please. So, as I already spoke earlier about the dashboard which we have developed and ranking mechanism. So this dashboard which we have developed has been adopted by NCDC, Government of India, and it has been embedded in the IHIP portal. So we have developed this dashboard at state level and district level also, and many districts are using this dashboard to generate their information up till block level and below to track the progress of various block and reporting units over a period of time. Another innovative method was to share the SPL reporting levels to concerned stakeholders every day, so that the awareness of IHIP is generated and every stakeholder is abreast of the latest status. So we share with more than 250 stakeholders, right from state level SSO to district officials on their respective status. So state level stakeholder is being shared, the status of SPL of the entire state. Divisional level authorities are shared, divisional level status, and a district CMHO civil surgeons are shared the status of their respective districts. And it has been acknowledged and appreciated by state IDSP cell in various meetings. Next, please. So these were some of the efforts we have put in MP, and I'd like to move to Maharashtra, which is another large state where we are supporting IDSP implementation. So in this, apart from many activities which we are supporting in MPs, there are some other innovative things which we have done, including development of checklist and handbook for IHIP users, the development of learning resources, including small videos in local languages, development of frequently asked questions for IHIP users, and supervision. Hello.
Sorry, Dr. Avinash, just sorry to jump in. We probably are running short of time, so I would request you to please finish up the session quickly so that we can have some time for the discussions of the questions. We have some questions from the chat as well.
Okay.
Thank you.
So give me 5 more minutes. I'll just wind up in 5 minutes. So in Maharashtra, we have utilized the state resources to strengthen the surveillance activities, and weekly review meetings have been held. Data which has been reported within the IDSP IHIP related to waterborne disease, the vector-borne disease of last 7 years were compiled and shared with the state, which focused on identification of region-wise disease patterns, and it led to focused activities and better planning and preparedness, respectively. Next, please. In Gadchiroli, falciparum malaria is an endemic, and it leads to several deaths annually. So, an active supervision mechanism were developed in coordination with the vector-borne disease surveillance programs, and the findings of supervision were shared with decision makers, and it led to strengthening entomological surveillance in the districts. Next, please. Manipur model I've already shared. Please, can you move to next slide, and I'd like to share some highlights on integrated public health laboratories. So integrated public health laboratories are being set up through PM Abhim across the country, and we are supporting in MP, Maharashtra, and 6 northeastern states in strengthening integrated public health laboratories. And the integrated public health laboratory concept moves around integration of all the labs and all the programs under one roof. So we are providing in MP end-to-end technical assistance in strengthening, in establishment, operationalization, and strengthening of lab structures. So we have conducted baseline assessments of IPHLs. We have contributed in development of layouts as well as development of BOQs. We are supporting in the development of learning resource packages for strengthening capacities of lab technician as well as especially staff on technical components as well as quality assurance and reporting and recording mechanisms. Next slide, please. So IPHL is a biosafety level 2 laboratory, which is been envisaged to be built around in 5,000 square feet area, which includes section on serology, hematology, clinical pathology, microbiology, molecular biology, and it has more than 118 tests and close to 5960 equipments, and all the basic as well as advanced tests are being envisaged to be done at district level only, and it will be a major boon to health system as well as surveillance activities, and it will if I talk on in the terms of surveillance, outbreak in identification is a major challenge because the district level lab infrastructure is currently very weak in most of the districts, and most of the lab related tests which are microbiological in nature, including cultures, antibiotic sensitivity, and all those things are currently happening at the medical colleges level only. So we are trying to strengthen the lab mechanism, and hopefully in coming time we would be able to identify the outbreaks more efficiently and more timely, so that the preventive and control measures are initiated appropriately. Thank you.
Thank you, Dr. Avinash, for that wonderful insight and letting us know about what's happening in the space of integrated disease surveillance and the innovation that JPIGO has done along with USAID about integrated health information platform. That's really great to know that. There are certain questions I think put forward by our audience in the chat. Stuti or Srikant, you want to post that?
Yes.
Thank you. The first question was by Supriya to Dr. Angela. Supriya wants to know, was the early warning signals equipped to provide information and alert to authorities on an impending surge of COVID cases in specific locations?
Hi, I've answered that in the chat. No, we didn't do hotspotting with a switch system like what we have in Bangalore. It was serving more as an early warning signal, and that was enough to share whether the BBMP COVID War Room should bump up their resources towards prevention and preparing the hospitals. They were not used for hotspotting, and I would imagine something like that would be fairly expensive and hard to do given the way our sewer networks are planned in the cities.
Thanks, Dr. Angela. So
yes, I have answered this as well. It can be done in an independent manner, but it's good. Someone later said that someone from, I think Victoria said what they call as integrated surveillance system. It's good to have the integrated sense-making platform to shift, to separate the noise from the signals. But this one can be, it is independently, implemented. It doesn't have to go with the other surveillance systems. It's ideal if they are together, of course.
Thanks, Dr. Angela. Yeah, the next question is from Latika to Dr. Avinash about IHIP. Is IHIP forms are online or they are offline?
Yeah, so Latika and everyone, the reporting in IHIP is online in In web portal captures P and L form reporting, and S form reporting is offline through IHIP mobile application, and the data gets synced as and when the network is available, and S form gets reflected onto IHIP as well. Currently, S form is not linked to P and L, but P and L forms are linked. So as and when the medical officer reports it online, the information is transferred to lab, and a lab person is required to fill in the results of the lab investigation demanded by the medical officer. So PNL form, the entry needs to be done online on web portal, and S form, ANM can report it through mobile application, which can be done offline also, and it gets synced later on. Dr. Akhtar, you are on mute.
Thank you, Dr. Jaiswal. Dr. Akhtar, would you like to take this question on?
Yeah, so it's not exactly a question, it's more of a suggestion from Dr. Vitali, who is a eminent researcher in Sydney University, about having some separate session on genomic sequencing. And he rightly pointed out that Dr. Angela, in her presentation, rightly mentioned about the other use of wastewater surveillance, and how that can be used for genomic surveillance or sequencing for other organisms as well, of pathogenic potentials like flu and monkeypox or any other conditions. Even in Australia, there are discussions happening at the moment, and in other places as well, using sewage water for antimicrobial resistance. How can we identify like AMS issues using wastewater? Of course, we do need like an integrated, where we can merge both integrated surveillance as well as, or you can say wastewater surveillance and syndromic surveillance, so that we can have a more holistic picture and can cancel some of the noise. And it's a really good suggestion. So I think I have one question to Avinash about IDSP. You were talking, that's a real great work that your team are doing. Is there any future plans to incorporate or integrate private practitioners into the process, so that we have more integrated picture? Because it's only capturing at the moment from the community as well as from PHC only, but we know that larger part of Indian health system are private health systems. So is there any process in plan, or working with the government to have some regulations or any other method that we can incorporate private practitioners or the hospitals within this process?
Thank you, Dr. Akhtar, for the question. So although there is no regulation or mandate for private providers to report into IHIP, but IHIP user IDs have been created for private providers also, and we have trained them also for reporting P and L forms. And any reporting units can be incorporated into IHIP. So it's not only limited to public sector, but private sector is very much involved in this. But there are certainly many challenges and gaps which needs to be addressed to strengthen reporting from private providers, and we are constantly following up with reporting units, private practitioners, private hospitals, medical colleges, to report P&L cases into IHIP. So it is already there. You are mute or on mute. You are on mute.
Once again, I would like to thank Dr. Angela and Dr. Avinash for their sharing their insight. And in the interest of time, I would like to hand over Dr. Habib Hassan Faruqi, who is an additional professor with Indian Institute of Public Health, Delhi, to share with us the summary and conclusion for today's session.
Thank you.
Over to you, Dr. Habib.
Thank you, Akhtar. Thank you very much. It's a great pleasure to be here with the very insightful audience. Just before I summarize my understanding from the session, and I'd like to take this opportunity to actually thank Dr. Angela and Avinash for sharing very insightful work they have been doing. And I am really appreciative of the work that Precision Health is doing. And I understand that, as Dr. Reddy started, set the stage by asking three important points. One was about using surveillance as the bedrock for resilient health system. The second was about need for the global policy, global governance structure, so as to ensure that these innovative technologies are available to the countries, especially LMIC countries who don't have know-how in terms of the technology and also in terms of the resources to be able to implement. And third was actually about understanding the real need or the concerns of not just the end users, but the people from where the data is being gathered. And I understand that those genuine questions and genuine concerns, I think to a large extent have been addressed, I think, in the work that has been done by the Precision Health. And I'm really impressed by the way that they have used the technology platform to actually, I would say, holistically integrate a lot of dimensions. One, I can clearly see what Dr. Angela mentioned about is about focus on the equity from the perspective of access to care, equity from the perspective of access to, say, diagnostic. And then she also mentioned, and their platform has nicely integrated what I would see is an important public health tool, which is say surveillance or public health surveillance using technology with the stakeholders. So I'm really impressed the way they have been able to actually use the digitalization not only to actually provide the transparent systems which are available to all the stakeholders in the real time, and also the way they have leveraged the technology to actually, or the digitization of the platform to have cross collaboration between different stakeholders, and also to set up the communication, because from the perspective of the surveillance, given that the information is really important from the perspective of the timeliness, having a real-time transparent conversation with the stakeholders, especially the government, and the rapid responses is really key. So I congratulate Dr. Angela and the team's work on Precision Health to demonstrate in a sense how to best integrate the technology to bring together all the stakeholders to work collaboratively and in a more, I would say, optimistic manner with all the stakeholders, and to provide these benefits to the community by addressing their goals of equity. So that's my takeaway from Dr. Angela's work that she has been doing in down south in Bangalore and other parts of the country. And I'm really impressed with Dr. Avinash's work also. I once was an SMO in UP, and I worked in those remote areas. I really appreciate the kind of the work he has been doing by integrating, those paper-based systems of integrated surveillance into a digital platform. And I really appreciate the work that he has been doing with JPIGO and USAID, especially in terms of, I would say, digitizing the network that already exists and providing a real-time feedback to the key stakeholders. And as he mentioned, that it actually brings in all the loads of information from not only villages through ANMs and also from PSCs through doctors and integration of the lab. And I really appreciate, and I hope all the audience and the members who are present in this meeting would have been really benefited by the way that this team has been able to actually integrate the existing platforms to a digital platform. And I also see greatly the way they have actually tried to bring in all the stakeholders at those parts of the country which are really to be, in a sense, from the limelight. They are really remote in terms of the kind of the work they are doing, and they are providing voice and they are providing information feedback to the central government and feedback to the state governments in order to actually respond quickly and on time. So congratulations to both the presenters, and I personally, and I am sure that other members who are listening to this webinar probably have immensely benefited from the work that has really demonstrated how these technologies and I mean, given the commitment to the cause, these technologies can be embedded into the existing systems to benefit to the public health. Thank you very much from my side. And over to Dr. Stuti.
Thank you. Thank you, Professor Hussain. I see that we have Mr. Jack Langenbrunner and Dr. Aida, who are esteemed members of our technical advisory group. So it would indeed be a waste if they're here and they're not able to make their comment. So would love to hear from you, Jack, Aida, if you would like to pitch in, please.
Thank you, Stuti. I'm going to defer to our other panelists. I really enjoyed the presentations, very interesting, lots of good information, but I don't have any particular questions at this point. Over.
Thank you, Jack.
Thank you, Stuti, Dr. Stuti, and all distinguished experts. I'm really impressed with this program and the way you presented. It also triggered my curiosity because of the need now to highlight the points that we can make with regard to the place that digital technologies can play in terms of addressing the nexus of issues like environment and health. And we also looked at economy nexus with the environment. And now I'm preparing a publication, like a little compendium of good practices of how to leverage digital transformation to facilitate climate action. And we know that water-related issues are like 90% affect the climate decisions, right? Because either we have too much water or not enough water, or water is polluted. It's also creating a lot of impact. So I wonder if I can follow up on that. I will explore further and actually promote your projects to our colleagues, and maybe we can present it as a best case scenario in the compendium of the best cases to deal with digital transformation. Because yeah, dealing with not only with civilians but also with informed decision making and healthcare at early stages. So I think it's amazing. Thank you.
Thank you so much, Dr. Idea. Thank you so much, Dr. Hussain, for wrapping up the discussions over the past hour and a half so precisely and wonderfully. I extend my deep gratitude to all of you on behalf of the entire team at the GLC4HSR and Access Health for joining us here today. A special thanks to those
We have lost you, Stuti.
Stuti, you're on mute.
You're muted.
I'm not on mute. Maybe my connection was unstable. So as I was saying, needless to say, a very big thank you to all our panelists and speakers, Dr. Akhtar, Dr. Angela, and Dr. Avinash for sharing their insights and experiences in this very important area of surveillance. Please feel free to reach out to us if you're interested in knowing more about the GLC, if you're not already formally associated with us. Please also give us your valuable feedback on how we can further improve these sessions going forward. Thank you so much. Have a good evening and a great weekend ahead.
Thank you very much for having me.
Thank you.
Thank you, everyone.